Welcome back to Mysteries of Health Under a Lens. If you are new here, I am a doctor currently completing my residency in pathology, and my goal is to help you understand what's happening at the microscopic level. Just a quick disclaimer before we begin. This video is a professional medical review intended strictly for residency preparation, lab analysis, and objective diagnostic education. I will be focusing purely on the high yield biopsy findings and underlying disease mechanisms rather than clinical management or treatment protocols. Please do not use this information as a replacement for medical advice. Today, we are going to break down hematology cases for exam going MD pathology students. Alright, then, let's get started.
So this is the fourth session which I am attending, and in every session, in every year, I have done one or two classes. So what I have done is basically I have provided 3 cases, and through these 3 cases, I'll try to discuss how we really approach in real life practice. So it's not just morphology. All the students should understand that though in exam we get a limited history, and we are forced to make a diagnosis. And usually in such situations, they are usually classical cases which are kept in the exam. So I'm not going into that situation. Rather, I have kept 3 uncommon cases through which I'll try to discuss how we approach. So as is well known, every diagnosis starts with a detailed clinical history. Especially in hematology, we cannot proceed without a clear-cut clinical history. Then, of course, morphology, and I can say that morphology is part of the clinical diagnosis nowadays. And then, of course, we have to add the ancillary investigations like immunophenotyping, cytogenetics, and other advanced investigations. Now, specifically, I have kept 3 bone marrow cases for today's discussion. So what I want to highlight is we have to, whatever is, even if it looks very similar, we have to follow a very systematic method to evaluate a bone marrow sample. So in different situations, like in some hospitals, both all the peripheral smear and the bone marrow aspirate and the biopsy are seen together by the same pathologist. There are situations where the peripheral blood and the bone marrow aspirate is seen by a set of people, and the biopsy goes to a different department. So so there are different situations. So irrespective of whatever is the method or whatever is the system followed in different institutes, whatever we get the sample, that sample has to be evaluated in a systematic way. So, for example, in the in the bone marrow, we have to assess the cellularity, whether it's a normo, hypercellular. Then in the low power, we have to see whether the megakaryocytes are adequately represented. Then whether the erythroids are adequately represented, is it normoblastic or megaloblastic? Then, of course, the myeloid series, whether the maturation is normal and well represented, and what is the blast percentage. And then each lineage has to be assessed uh, uh, systematically for the presence or absence of any dysplasia. And then, are there any other abnormal cells in the bone marrow? The purge stain is very important, and it should be done routinely in all cases to look for the iron stores as well as the presence or absence of ring sideroblast, and of course the fibrosis. This is a very brief summary of what we have to see in a bone marrow sample. Now let's start with before going to the first case. Swati is available, and
Yes, sir.
okay. So what are these cells? What is this cell, and what are these cells?
These are neutrophils.
This one is this is a neutrophil. What about this one? These ones?
These ones are RBCs.
No. These cells. Oh, sorry. These 2 cells.
Megakaryocytes.
Okay, so basically, this is a neutrophil, it's a segmented cell, right? But these two are eosinophils, right? These two are eosinophils. So the granules are subtly different. These are coarse orangish granules. These are fine eosinophilic granules. So we classically teach that the eosinophils are bilobed with orangish granule. But remember that they are the normal ones. But when there is a reaction, the eosinophils can have 3 or 4 or 5 lobes. Even single lobes can also be seen. So the characteristic feature is the presence of these kind of orangish granules. The bilobation or these two lobes are given the less importance compared to the characteristic of the color of the granule. So these are eosinophils and this is a neutrophil. Now, what is eosinophilia, Ruchika? What is the definition of eosinophilia?
So it's the increase in number of eosinophils more than 10% in peripheral blood smears.
What about the absolute eosinophil count? What is the cutoff for eosinophilia? It is 500, like 500 per microliter. The more than 10%, we usually use a cutoff of more than 500 per microliter. What about hypereosinophilia?
Eosinophil
It is more than
into the
1500 per microliter.
more than
What is
100.
hypereosinophilic syndrome? Anyone, like Mugilan or Sharavanan, anyone can. But please respond quickly so that we can save time and move faster. So when the eosinophilia is accompanied by an end organ dysfunction like a cardiac failure or a neurological dysfunction or something, then we call it as a hypereosinophilic syndrome. Okay, so hypereosinophilia is just the presence of eosinophils. The patient can, an individual can have a very high eosinophil count and may be asymptomatic, but if it is associated with symptoms of organ dysfunction, then it is called hypereosinophilic syndrome. What is clonal eosinophilia and what is secondary eosinophilia? Anyone quickly? Okay, so clonal or primary eosinophil is a situation where all the eosinophils are cloned, the same clone, okay? Whereas secondary eosinophilia is a eosinophilia which is secondary or reactive to some other condition. Okay, so that is clonal eosinophilia. That means all are same, of the same clone. It's from the same clone which all the eosinophils are coming. And so it's called primary eosinophilia. And the secondary eosinophilia situation where the eosinophilia is occurring secondary to some other infectious or drugs or inflammatory condition or an allergy or something like that. So what about eosinophil TALL? Is it clonal eosinophilia or secondary?
Clonal.
Clonal as
No, clonal. So it is here the eosinophilia is, so the TLL, what is a clone? It's a T cell, right? T lymphoblasts are the clonal cells. And eosinophilia is secondary to that clonal process. So the eosinophils are not clonal in TLL or a Hodgkin's lymphoma or some other cancer, many cancers. The eosinophils are secondary to a clonal process. Whereas in acute myeloid leukemia or a chronic eosinophilic leukemia or a CML or some other myeloproliferative neoplasm, the eosinophilia is part of the clone. So it is a clonal eosinophilia. So eosinophilia in BALL, TALL, some large lymphocyte leukemias or T lymphomas or Hodgkin's lymphoma or AATL, these are not clonal. Though there is a clonal process in the background, the eosinophilia is secondary. Whereas in myeloid neoplasm, in majority of the myeloid neoplasms, the eosinophilia is clonal. Okay. So with this, one more question. So whenever we deal with the eosinophils, so here you can see there are eosinophils with multiple lobes. So there's a neutrophil, there are eosinophils with 4 or 5 lobes. You can see there are a lot of vacuoles here. There are eosinophils with the one side completely agranular. So somebody has commented that the volume is very low. Is it same for everyone or can you hear properly?
Sir, you're audible, sir.
Yes, okay, right. So, so you can see there are abnormalities in the eosinophils, right? Here the lobes are a problem. Here the vacuoles are there. Here it's a partially degranulated. So based upon these features, can we say that these are abnormal or clonal? So many people will tend to say that since there is a morphological abnormality, it's a part of the clonal process. Actually, it is not. So eosinophils are one group of cells, because in many, like in neutrophils, we have definite dysplastic features. In monocytes and myelocytes and all megakaryocytes, we have clear-cut definite. So when the morphology is abnormal, we tend to say it's dysplastic or abnormal. But in eosinophils, the lobe abnormalities or the vacuolations or the partial degranulation, these are not considered dysplasia. Okay, so any reactive eosinophilia can have these kind of abnormalities. Similarly, abnormal eosinophil count, even very high, more than 5,000, cannot confirm that it is a clonal or a malignant process. Okay, so for the people who are confused between, actually speaking, malignancy and clone are not same, but for easy understanding, maybe I'm saying that by just looking at the morphology of eosinophils, we should not conclude that these are abnormal or malignant or clonal. Even the presence or absence of organ dysfunction does not predict that eosinophilia is clonal. So eosinophilia is distinct, that it is very difficult to predict whether it is a clonal or a malignant process. But this is one morphological abnormality which says that this is likely to be a clonal. In which condition do you get these kind of eosinophils? Swati or Ruchika, anyone? Eosinophils with black granules? Which AML, cytogenetic abnormality associated AML shows these kind of eosinophils and precursors?
So inversion.
Inversion 16, correct. Inversion 16. You have eosinophils with this kind of granules. So this is one abnormality which might predict that there is an underlying clonal process, but not the others. So in case of eosinophilia, cases with eosinophilia, so how do we approach? It depends upon whether there is an urgency or evidence of organ failure. If there is an organ failure, the patient is present with cardiac failure or a neurological dysfunction, we might have to go for an all-out investigation. We might have to go for a comprehensive investigation at that point itself. But if there is no organ dysfunction, we can go in a stepwise manner, starting with exclusion of a reactive process like an allergy or an infection or some other drugs or some secondary processes, followed by exclusion of a malignancy. But if there is an urgency, we'll have to go for all the investigations at the beginning itself. So always the question is it clonal eosinophilia or is it reactive eosinophilia? Because the reactive eosinophilia is managed by steroids or some anti-helminthic drugs or some other medications like interleukin-5 receptor antagonists or something like that. But for a clonal eosinophilia, we might have to go for some other kind of a management. So what are the factors which predicts that a condition is clonal? If there is a significant hepatosplenomegaly, so the organ dysfunction does not predict clonal eosinophilia, but if there is significant hepatosplenomegaly, it is likely, again, they are not definite, it is likely to be clonal. Significant anemia, which is not nutritional or thrombocytopenia associated with eosinophilia, presence of a significant left shift or blast in the peripheral blood, more than 5% blast in the bone marrow aspirate, the presence of those coarse granules in the eosinophils, which I just showed in the previous slide, the presence of myelofibrosis. This is one important point in bone marrow. If the bone marrow shows myelofibrosis, this is unlikely to be reactive. The presence of dysplastic megakaryocytes or other dysplastic cells, mastocytosis. Remember that systemic mastocytosis can associate with eosinophilia. Some of the eosinophilic syndromes are associated with mastocytosis. And biochemical presence of high vitamin B12 or serum tryptase is another pointer which points towards a clonal eosinophil. Of this, the presence of significant hepatosplenomegaly, the presence of myelofibrosis, dysplastic megakaryocytes, and mastocytosis has got a very high predictive value for the presence of clonal eosinophilia. So coming to the first case, so this was a 35-year-old male with anemia for 3 months with cervical and axillary lymphadenopathy and hepatosplenomegaly. Bone marrow aspirated was dry tap and the trephine section was provided. So in real life situation also, we might not have a good aspirate for morphological evaluation. So even though we have to, assess it comprehensively, that the peripheral blood film plus aspirate plus biopsy, there are situations where we might have to look at the trephine biopsy alone and give a diagnosis. This is a real life situation because we might end up with a dry tab in many cases, So this is such a situation. So what are the differential diagnoses for a condition anemia with lymph node plus hepatosplenomegaly, and who is undergoing bone marrow examination? There might be plenty of causes, but suppose a clinician is ordering for a bone marrow examination in such a situation, we should think about a leukemia, a lymphoma, a myeloproliferative neoplasm in blast crisis or an extramedullary involvement, because usually the MPN will not have lymphadenopathy, but if it is presenting in a blast crisis or sometimes with extramedullary lymph involvement, the lymphadenopathy might be there. Then granulomatous pathology like tuberculosis can have this kind of situation, or a sarcoidosis, and of course metastasis may also present with such a scenario. So this was the biopsy. If somebody is ready to quickly describe, please describe this biopsy. Quick and crisp. So this is around 37-year-old person. So
Sir,
cellular
hypocellular, sir.
hypercellular.
Hypos.
Hypo, why are you saying hypocellular?
Hypercellular marrow.
It's hypercellular, right? Then
A megakaryocytes.
Megakaryocytes.
one person, actually somebody, okay, who is Ruchika can describe. Okay, it's a hypercellular
Here
marrow.
in this trephine biopsy, we can see that it's a hypercellular marrow,
Yes.
and we can see that the megakaryocytes are slightly increased and they are showing variation. Some are hyperchromatic, some are looking hyperchromatic.
Megakaryocytes, some
They have,
dysplastic morphology is there. Then what are these?
and so we can appreciate fibrosis.
Fibrosis is there. Are bands of fibrosis are there. Then what are these?
And so,
What are these?
and so we can see eosinophils also.
These are collections of
Uh,
eosinophils. So the
Yes,
major
eosinophils.
yes. So the major finding. So again, there are collections of eosinophils. So
Yes.
most of you will be easily identifying all the cells in the aspirate, but you should also learn how to identify these cells in the biopsy. Okay. So these are eosinophils. Okay. Some say mast cells can also be, look like this, but their nucleus will be more regular. Okay. So these are eosinophils. So this is a hypercellular marrow. There are fibrotic bands. There are aggregates of eosinophils and precursors. Megakaryocytes are increased. There is dysplasia in the megakaryocytes, and the erythroid cells are reduced. So this is the reticulin stains, which highlights the diffuse fibrosis. With fragments, there are strands with more fibrosis, but there is a diffuse fibrosis, right? So what is the differential diagnosis of a hypercellular marrow with eosinophilia with fibrosis? The first and foremost is myeloproliferative neoplasm. Okay. Whatever is, because statistically CML is always more common than any other myeloproliferative neoplasm, right? So we have to, and CML can also present with eosinophils. There are some CMLs which will have a preponderance of eosinophils and precursors. So mind that. So we the first and foremost differential diagnosis is the CML. Second is the chronic eosinophilic leukemia, and other uncommon MPNs like MPMF, but PMF typically, majority of the cases usually do not show this kind of eosinophilia. And the next important group of neoplasms are the myeloid/lymphoid neoplasms with eosinophilia and tyrosine kinase gene fusions. Okay, so you know about that. These are the myeloid lymphoid neoplasms with the PDGFR B, FGFR1, JAK2, all those rearrangements. So basically, they are tyrosine kinase domain fusions. Mastocytosis, as I described previously, the systemic mastocytosis can present with eosinophilia, and eosinophilia sometimes will have mast cell clusters. Very infrequently, infiltration by lymphomas like Hodgkin's and AATL can also have this picture. So if the bone marrow aspirate is available, we should go with an immunophenotyping to look for abnormal B cells, T cells, myeloid precursor, if there are any immunophenotypic aberrants in the myeloid precursors, and of course mast cell flow cytometry, because B cell neoplasms can present with eosinophilia, T cell lymphomas can present eosinophilia. The aberrancies in the myeloid precursors help to say that this is a myeloid neoplasm with eosinophilia, and aberrancies in the mast cells, like the presence of CD2 or 25 in the mast cells, helps to say that these are abnormal mast cells. So if the aspirate is available, we usually go for the next step is to go for a flow cytometry to assess all these cells. Because the reactive eosinophilia, as I described previously, can accompany TLBLs, AITLs, and various NHLs. Similarly, abnormal B clones can be associated with eosinophilias. This IGH IL3 is a very peculiar entity where the percentage of B blasts can be as low as 5%. So the eosinophilia can completely, mask the underlying B cell, abnormal B cell lymphoblast. So we always go for flow cytometry to look for abnormal B T cells in cases of eosinophilia. Now, but here we have only trephine biopsy, so we cannot go for the flow cytometry. We have to go for immunohistochemistry. And as you know, all the antibodies which are available in flow cytometry, all those antibodies are not good enough to be done as part of immunohistochemistry. So what we usually do is CD20, CD3, along with CD117. Mast cell tryptase is available with us, and 22530, because the presence of abnormal mast cells, again, as I told, it will help to say that this is a clonal process. That's why we are putting that. Of course, we'll put BNT markers to exclude an underlying lymphoproliferative process. So this is the mast cell tryptase immunohistochemistry in this case. So if you do it regularly, you know that this is much more than what we usually see, but they are not in clusters. So if they were in clusters, we would have thought of mastocytosis, but here they are interstitially increased. They are not in clusters, but these are all mast cells which are. So again, this is a very important clue. So if you do mast cell tryptase and if it is increased in a case of eosinophilia, you are likely to be dealing with a clonal eosinophilia and not a reactive process. Okay. So we did IHC. There were no abnormal B or T cells. The mast cells were subtly increased. The next step is to do cytogenetics. So conventional karyotyping is the part of the process. We have to do it to look for various cytogenetic abnormalities. Irrespective of conventional karyotyping, we should always look for these abnormalities. BCR-ABL, RUNX1T1, 4 binding factor MYH11, FIP1 PDGFR-A, PDGFR-B. This is because majority of these abnormalities are cryptic and fail to be detected by conventional karyotyping. So you have to go for some molecular cytogenetic technique, either RT-PCR or a FISH, to look for these fusions. And if it's negative for these fusions, we have to look for we have to do an NGS for a myeloid mutation panel to detect underlying clonal abnormalities. So why are we doing it? Because you know that as per the latest WHO, the blast percentage is irrelevant. If we detect these are RUNX1, RUNX21 or 4 binding factor MYH11, we can diagnose AML, and these cytogenetic abnormalities are often associated with eosinophilias. BCR-ABL is one of the frequent, the most common MP, and it is very frequently associated with eosinophilia. Other cytogenetic abnormalities these are the ones which are, many of these are tyrosine kinase fusions, and if we diagnose them, we can diagnose myeloid lymphoid neoplasms with eosinophilia. It's very important to understand the morphology of these are very varied. They can present with BALL, TLL, mixed phenotypic leukemias, MDS, MPN, or there are wide variety of presentations, but the common point is the presence of eosinophilia. So why is it important to identify the cytogenetic abnormalities? They are targetable, because if there is a PDGFR is positive, these patients respond to low dose imatinib. PDGFR-B also responds to imatinib. Similarly, other cytogenetic abnormalities, these tyrosine kinase fusions responds to either some of the well-defined, easily available tyrosine kinase inhibitors or many of those experimental drugs. So in this case, so there is a eosinophilia. We could not do flow cytometry. IHC showed increase in mast cells. Next, we did cytogenetics. So we looked for this PDGFR-A, PDGFR-B, FGFR, JAK2, ABL1. This is our cytogenetic panel. Along with that, since there was some megakaryocytic dysplasia, we also looked for chromosome 5, 7, 8, and 20 as part of the MDS panel. So what we did, we found was it was negative for these tyrosine kinase fusions. It was negative for PDGFR-A, B, FGFR1, JAK2, and ABL1. But there were 3 copies of chromosome 8. So the trisomy 8 was there, and there was 7q deletion. You can see that there are 2 green from the centromere, only 1 orange, so the other orange is missing. So the 7q is, so there is a underlying clonal cytogenetic abnormality. So it makes it clear that we are dealing with a clonal process. So there were no fusions, but cytogenetic abnormalities were present. So what next? So since the fusions are not present, we should go for NGS in this case for completion of the workup. Why? Because the diagnosis of chronic eosinophilic leukemia becomes a priority at that point, because we have excluded well-defined, majority of the well-defined myeloid neoplasms like CML, myeloid lymphoneoplasms with eosinophilia and tyrosine kinase fusions. So the next thing which we have to consider is a chronic eosinophilic leukemia, so which is characterized by the peripheral blood eosinophilia, blast less than 20%, no tyrosine kinase gene fusions. It does not meet the criteria for other well-defined myeloproliferative neoplasms. And of course, the bone marrow morphology should be suggestive of a CEL, which is characterized by the presence of increased cellularity, dysplastic megakaryocytes, with or without dysplasia in the other lineages. And it will be supported if we can demonstrate a clonal cytogenetic abnormality or a somatic mutation. So we have already demonstrated a cytogenetic abnormality in the presence of trisomy 8 and 7q. Further, by NGS, this case had a STAT5 mutation. So we should remember that STAT5B, this mutation is a very frequent cytogenetic mutation in chronic eosinophilic leukemias. So the final diagnosis is chronic eosinophilic leukemia. So we excluded reactive conditions. Then we excluded common conditions like CMLs and AML with RNX1T1 or core binding factor leukemias. Then we excluded eosinophilias with tyrosine kinase gene fusions. Then we demonstrated cytogenetic abnormalities and mutations to make a diagnosis of chronic eosinophilic leukemia. So this, if you want to read about it, there is a review. There are reviews on eosinophilias. So suppose what I want to highlight is there might be many centers which does not have flow or a cytogenetics or an NGS, but these points will help to say that this is, you are likely to be dealing with a clonal process. If there is a significant hepatosplenomegaly, more than 5% blast and aspirate, myelofibrosis in bone marrow, dysplastic megakaryocytes, and presence of mastocytosis. Okay. So any doubt? If you have some queries, we can quickly clarify and before going to the next case.
So sorry to interrupt you, sir. So there
Yes.
are requests from participants that the pointer is not visible in the micro photographs.
This is not visible?
So while marking it is visible, sir. In the micro photographs, the
It's not
marker is also white in color.
Okay,
So
let's see. Okay, I'll come to that. Can you see this? No, not visible.
so when you mark, it is visible. Otherwise, since
Okay, right. So I have to mark it. Okay, understood. Right. Okay.
Thank you, sir.
So any other doubt, please? We can clarify and So there is a question that why is vitamin B12 high in eosinophil? So basically, in almost majority of the myeloid neoplasms, the B12 can be high. So there is a particular isoform of B12 which is present in leukocytes. So when there is a leukocyte proliferation, that particular isoform will be high in the serum. Okay, that clarifies it. So this is present in leukocytes. Any other doubt? Morphology, anything to clarify? Okay, so I think, so we'll move to the next case. This was the second case is a 72-year-old elderly female, known case of PLHA on antiretroviral therapy for 12 years. So she was referred in view of multiple lytic lesions in the vertebrae, largest 2 centimeters. On examination, no lymphadenopathy or hepatosplenopathy. So basically, multiple lytic lesions, and she's on antiretroviral therapy for last 12 years. So what are the differential diagnosis for multiple lytic lesions who's undergoing a bone marrow examination? Anyone, please? Sharavana?
Yes, sir. Multiple myeloma, plasmablastic lymphoma.
Okay.
So plasma cell leukemia.
Okay, so these are plasma cell neoplasms. Fine. Then
Metastasis.
metastasis. Correct. Then
Yes.
if it's a child, young person. So plasma cell neoplasms, Langerhans cell histiocytosis,
Yes.
metastasis, and of course some other, like sometimes infections can present. There are very uncommon conditions. Sometimes the patients with renal failure on chronic dialysis can develop these kind of bony abnormalities, and there are many other, but the common ones are myelomas, some primary bone marrow lymphomas, Langerhans histiocytosis, and metastasis, right? So again, somebody, I think Sharavanan should describe this case.
Sir, it shows focal osteolysis of bony trabeculae.
Okay, yes, bony trabeculae very irregular and thinned out, correct?
Yes, sir. Sir, it shows monomorphic sheets of cells.
Okay, right.
With eccentric nuclei.
This is eccentric nucleus.
Yeah.
Is it eccentric? What is the shape of the cell?
Spindle. It's spindle.
The spindle cells. And
Yes,
the shape of the nucleus?
elongated.
Ovoid, right?
Yes.
Are they like very aggressive looking, or are they bland looking, or how do you describe that?
Bland.
Yes, sir. Bland.
Very bland, right?
Yes.
These are sheets of spindle cells with
Cells.
ovoid, very bland appearing nucleus. What about the cytoplasm? Is it scanty? Is it basophilic? Is
It's
it
base.
Is it basophilic?
Scant cell.
They are not scanty, right? So the scant, maybe the lymphocytes are, these are scanty ones, right?
Oh.
These are not scanty. You can see the cytoplasm, right? So this is a
Yes, sir.
nucleus. You have cytoplasm, plenty of cytoplasm.
Yes.
This is very eosinophilic. Okay, this is much more eosinophilic. This is much more eosinophilic. This is probably a plasma cell, right? Eccentrically placed. But these are not eccentrically placed. They are spindle shaped cells, right? Okay, these ones. So, okay. So you have hypercellular bone marrow, aggregates of spindle cells. They have very eosinophilic cytoplasm, bland oval nucleus. And of course, you can see some lymphoid aggregates, right? You can see lymphoid aggregates with some plasma cells.
Yes.
Right? You can see the adjacent bones are being destroyed, right? You see, this is a part of the bone which is destroyed and replaced by these cells, right? Osteolysis is there. But there are no large atypical cells. So what are your differential diagnoses? Any differential diagnosis? Suppose you see these kind of cells on the skin, what will you think?
Mastocytosis.
Mastocytosis. Excellent. So mastocytosis, right? So the spindle cell lesions in the bone marrow are very rare, right? They are very, very rare. We see maybe 2 or 3 lesions in a year. But something which should not be missed is the fibroblastic proliferation in response to a Hodgkin's lymphoma. You see, when there is an infiltration by a Hodgkin's lymphoma, we get a polymorphous infiltrate of spindled fibroblasts plus lymphocytes plus eosinophils plus so many cells, right? So that is something which we should not miss. But what we have seen is different from Hodgkin's lymphoma, right? These are predominantly these spindle cells. Even though there is a lymphoid aggregate, there are no large Hodgkin's-like cells, and these spindle cells are completely replacing some of the marrow spaces. So we should always think about Hodgkin's lymphoma infiltration, but this is looking beyond that, right? So mastocytosis, you should always think about mastocytosis. Even though this is a bone marrow, you just imagine that, suppose this is a skin, we think about mastocytosis, right? Other sarcomas can rarely involve marrow, and they can have spindle morphology. Very, very uncommon. This is a HIV positive patient, so Kaposi sarcoma is another differential diagnosis. Again, very, very uncommon. Mycobacterial spindle cell tumors, again, bone marrow is an uncommon site. We can have lungs and pancreas and other organs. We can have this kind of pseudo tumors. So this is something which is like we should think about mastocytosis. Still, since the patient is HIV positive, we did AFB, FPAs to rule out organisms. So we didn't find any. We did a flow cytometry, okay, because myeloma is, of course, a differential diagnosis in any individual with lytic lesions, and sometimes this can be a kind of a patchy involvement. So there might be multiple. So there's something called macrofocal myelomas. So the X-ray will show multiple lytic lesions, but your aspirate might not have enough of plasma cells. So these are called macrofocal myelomas. So the flow cytometry is a very sensitive technique to detect clonal plasma cells. We did flow cytometry for plasma cells. So they were gated based on 38, 138, 45, and scatter. And the clonality was assessed based upon these markers and cytokappa lambda, but there were no clonal plasma cells. We did immunohistochemistry because there were lymphocytic aggregates using CD320, 138. And of course, since the mastocytosis is a differential diagnosis, we did IHC for mast cell tryptase and CD117 and HHV8 for Kaposi sarcoma. HHV8 was negative. This is the mast cell tryptase. You can see that they are beautifully positive, the cytoplasmic positive in all these cells. You can see this is mast cell tryptase. So if you don't have a mast cell tryptase, CD117 is equally good because CD117 will be brightly positive in mast cells. So the myeloid cells will be CD117 positive, but the brightest positive will be seen on mast cells. So if your lab does not have a mast cell tryptase, you can do CD117. So this is CD117, again positive. Now to show that whether these mast cells are abnormal or not, we can use CD225 and 30. So if these are positive, we can call it abnormal mast cells. So this is 25, which is positive. And if we can also do flow cytometry to document abnormal mast cells. So the mast cells are very brightly 117 and 33 positive. They are, if they're abnormal, they will be positive for CD2 and 25. Okay, so these can be tested by flow cytometry as well. And we did CD20. So this is these lymphoid aggregates are positive for a mixture of CD20 and CD3 positive cells. So remember that mastocytosis can be accompanied by reactive lymphoid aggregates. Okay, so you need not be alarmed by the presence of lymphoid aggregates in and especially bone marrow mastocytosis is very frequently associated with reactive lymphoid aggregates. And you have to go for molecular testing if possible, because c-KIT mutations are frequent in systemic mastocytosis. I'm not going into the theory of the systemic mastocytosis and how to classify it. You can read the WHO is described in very much detail. So here, since there were multiple lytic lesions and there was a mastocytosis in the bone marrow, we called it aggressive systemic mastocytosis, right? So this is a systematic way of how to diagnose a systemic mastocytosis in bone marrow. If you have any doubt, you can ask. Any clarifications? So in practice, more than systemic mastocytosis, a much frequent entity is basically a myeloid neoplasm with associated, you know that entity, right? 821 can be associated with systemic mastocytosis. Sometimes, you know, some of these AMLs may proceed with systemic mastocytosis. Some cases after therapy, this mastocytosis becomes prominent. So that is much more frequent than systemic mastocytosis. But just I thought of showing this case because this is very classical, and you should not miss. It might come once in a while, but this is the morphology is classic, and you should be able to diagnose it. Any doubt? So many people are, I mean, a few people are saying that my voice is not very much audible. Is it? I mean, the moderators are requesting.
You're not.
Please.
So I've requested them to check the audio settings at their end.
Okay. So the peripheral blood film, somebody is asking about the peripheral blood film, right? So basically, you know, there is a condition called mast cell leukemia. In that situation, you might see circulating mast cells. But in a majority of cases of systemic mastocytosis, it is difficult to identify circulating mast cells. So if you do a high sensitivity flow cytometry, you might be able to document the presence of mast cells, but morphologically, they are difficult. And in some situations, they can be confused with you know, some other very heavily granulated cells. So we had a couple of cases with circulating mast cells, but a good proportion of cases do not show mast cells in the peripheral blood. And there was a question that why mast cell looks spindled. Why is it looking spindled? I am unable to answer it. But in general, this is a morphological abnormality where we should suspect, you know, the spindle morphology should point towards a clonal process, because you know, reactive mast cells are usually round, and but the, you know, abnormal mast cells can have varied morphology. The spindled one being the more common one.
So there is also a question why plasma cells are seen in the peripheral blood smear.
Plasma cells can be seen in peripheral. Definitely, plasma cells can be seen. We know that it is very important to document the presence of circulating plasma cells, because you know the definition is based on the definition of plasma cell leukemia is based upon the percentage of circulating plasma cells, right? So it is very important to document the circulating plasma cells. But for mast cells, it is very difficult to document the presence of circulating mast cells. And there was a question, clinical features. The clinical features again were quite varied. You know, in this case there were lytic lesions. Some patients present with you know, these you know, this flushing and other features of high serum tryptase levels, you know, or histamine levels. And some patients may be asymptomatic. They are just incidentally detected. Some of our cases were just incidentally detected because these patients were evaluated for some anemia, and you know, this bone marrow mastocytosis was just an indolent and incidental find. I think in the interest of time, I think I should go to the last case because Karthik needs sufficient time to discuss his cases. So I'll quickly go through the next case. Okay. So again, I need somebody to identify these cells before going to the actual case. Mugilan is online.
Yes, sir. Neutrophils.
This one.
Band forms.
This one. Blast, right? This can be. Yes, sir, more granules have come up, so it's a later stage of type 3 blast or something. It's a blast. Yes. For this one, there's a half. promyelocyte, right?
Yes, sir.
Okay. Then what about these?
Metamyelocytes.
Metamyelocytes, right. What are these?
Myelocele.
What is
Faggot cells.
Faggot cells.
faggot cells? Or
Faggot.
diagnosis? What is the diagnosis?
AML,
More defined. Please define.
APML.
APML, it's a classical variant, right? Acute promyelocytic leukemia, classical morphology, right? So you can see these faggot cells, these are all rods, you know, these are like bilobed cells, heavily granulated. So this is classical APML. What about this?
Buttock shape.
Yes. Please define what is the diagnosis here. Microgranular variant of APML, right? So if you
Yes,
do
sir.
an MPO, it will be strongly positive, but in routine Romanowski stain, these granules are not well highlighted. But the morphology is classical. It is confused with which leukemia, which other AML? What is the closest differential diagnosis of microgranular variant of APML? Monocytic leukemias, right? Monocytic
Yes, sir.
leukemia. Yes. So this is the microgranular variant of APML, right? What about this?
Hypergranular.
Somebody clearly, please, Sharavanan or Swati, somebody please.
It's a hypergranular.
This is also a APML, right? This is
Yes.
hypergranular APML.
Hypergranular.
So you see APML, you call it APML, but you can have varied morphology. If you read the textbook, there's so many different, like some cases will have full of Chiria Higashi type of granules. There are so many varied varieties of so-called APML. And more than 95% of these cases will be positive for
MP. Why?
okay, MPO will be like nearly 99%. Nearly all cases will be MPO strongly positive. Which cytogenetic abnormality?
NP.
Which one? PML RARA, right? More than 95% cases of morphological APMLs will be positive for PML RARA, right? What about these cells? Now we have seen all the APMLs. Now somebody, Rutika can tell me, where will you place these cells? Are they blasts or promyelocytes or myelocytes or metamyelocytes or band forms or some other cell? What are these cells?
So these are actually, so they are having nucleoblast cells with hypergranular
Okay, you think
cytoplasmic granules in
you
the
are thinking that this
cytoplasm.
is blast. Anyone, there is any difference of opinion?
Promyelocytes.
Promyelocytes. Are they classical promyelocytes?
No.
Are they bilobed?
Myelin.
Do they have orods? Are they as hypergranular as usual classical APMLs? No, right? Is there anyone
Myelocytes.
that this is not at all a malignancy? If not a malignancy, what else will you think if you find these kind of cells? Suppose this patient is presenting with fever, some cytopenias,
So
and
large lymphocytes.
large granular lymphocytes usually will not have so much granules. Okay, you can confuse it, but maybe like when you see under a microscope, very unlikely to be. I mean, these are not looking like. They usually much, they're smaller and the granules are not these coarse. Any other differential? Suppose a patient is sick, fever.
Leukemoid reaction.
Reaction, you can't say leukemia reaction. Like that, you have seen only these kind of cells. And suppose this is a bone marrow. Before calling leukemia, what will you think of? Do you think of maturation arrest?
Saturation.
So these are like, reactive situations because of, sepsis or some drugs or some infection or inflammatory condition. The cells gets arrested at a particular stage, and that is called a maturation arrest. So the maturation arrest can be partial or it can be, complete. So even a complete maturation arrest can happen at a myelocyte stage, right? So at least think before, but if you have enough of megakaryocytes and other cells, and you are seeing these kind of cells, you should also think about maturation arrest. Okay, so this is a summary. So this is again another case of acute promyelocytic leukemia. You see that these cells are not classical bilobed abnormal promyelocytes, right? These are more of eccentrically placed nucleus, but the nucleus, the cytoplasm is very hypergranular. These are some of our cases. So again, I want to highlight that promyelocytic leukemia can have a varied morphology. Okay, we have to keep a high degree of suspicion so that these patients are not missed and they are not, they should be started as a therapy as soon as possible. So coming to the third case, 42 male, left hip pain since 3 months, no organomegaly, and MRI showed altered signal intensity, and the radiologist suspected some problem. Okay, so they advised a bone marrow examination. So this was a hemogram and the peripheral blood film. There was no significant anemia. There was mild anemia. TLC was on the higher side. Again, there was a platelet count was near normal. And you see this, the neutrophils, very less, occasional neutrophils, occasional blastoid cell. The majority of the cells were like this. Confusion, right? Straightforward, it is very difficult to say that they are blast or promyelocyte. They could be myelocytes, right? This kind of cells. In real life, it was a difficult case for us because it was difficult to directly suspect a leukemia just by seeing the peripheral blood fluid. Again, but majority of the cells were like this. Okay? The cells between the promyelocyte and myelocyte stage. Bone marrow aspirate. Majority of the cells were these cells. All these cells with eccentric nucleus and granular cytoplasm. Not classical abnormal promyelocyte, but there was a suspicion that this could be promyelocyte and this could be APML, right? All the cells were like this. MPO, strongly positive. Biopsy. You see this, it may be confused with a multiple myeloma, right? They were like very eosinophilic cytoplasm, very regular nucleus, eccentrically placed nucleus. If I see only this biopsy, I might confuse it with a plasma cell myeloma, but APML is another entity which can have this kind of a morphology. So this is the refined biopsy. So though the morphology was not classical of a APML, the features were highly suspicious of a APML. Okay. So what are the differential diagnoses? One is a maturation arrest and second is an APML. But since in this case there were all these cells and there were no other cells, it is very difficult to suspect a reactive condition or a maturation arrest. We should suspect acute leukemia. Okay, and next we did flow cytometry. So this is a classical appearance of the promyelocytes in flow cytometry. They were very high site scatter, right? So usually the neutrophils lie in this area, but here all the cells are lying in the same region as neutrophils with a very high site scatter. Inverted teardrop or whatever you can call it. And another feature is even without putting an antibody, they will show autofluorescence in all the channels. They will look positive. See, we usually, I'm not going to the details of how do we, analyze APML by flow cytometry, but we have to take, cutoffs from the negative to where there are no antibodies, and these quadrants are set based upon, based upon the negative tube. The negative tube means where there are no antibodies except for 45. You set these quadrants from these tubes, and then only those cells which is going beyond these quadrants will be called as positive. So you see this some 20 is expressed even without putting an antibody. Only if it comes beyond this quadrant, we call it as positive, right? So after flow cytometry, they were negative for the B cell markers, T cell markers. CD56 was positive. Myeloid markers were positive 1333, 117 NPO. They were negative for 15, 36, and 14, So you know that, no, I'm not going again due to lack of time. So CD19 is the pan B cell marker, cytocytosis is a pan T cell marker, or CD7 is another T cell marker, 14 is for monocytes, 15 is for granulocytes. This is very, very important. Usually APML will be negative for CD15. They are positive for 1333, and HLA-DR was negative. Okay, so usually HLA-DR and 34 is negative in APMLs, but some of the APMLs can have positive, but majority of the cases 34 and HLA-DR are negative. So the immunophenotype is also consistent with APML. So what is the next? The next important point is to document PML RARA. This is very, very important and it has to be done. So in some labs, a quick fish is done within 3 to 4 hours to document PML RARA, because this is very important before starting the ATO and arsenic trioxide and ATRA. Okay, or we can also use RT-PCR for documenting the PML RARA. So in this case, we did fish, and the fish. So normally we get 2 orange signals from the PML gene and 2 green signals from the 2 RARA genes. So when there is no fusion, these 2 orange and green lie separately. When there is a translocation, we get 1 or 2 fusions and 1 orange from the normal PML and 1 green from the normal RARA. So in this situation, actually, we got this pattern. There were no fusions, so there were 2 PML signals. Instead, there were 3 RARA signals. So the PML RARA was negative, but we got 3 copies from the RARA. This is very important signal from the fish, because this is indicative of a variant RARA translocation. RARA has so many partners. PML is the most common partner, which is seen in nearly 96 to 97% of the cases. Okay, so but in 3% of the cases, various other partners are seen. So what is the next step? So we did PML RARA, fish negative, but we got 3 RARA signals. So the next step is to do a RARA break apart fish. So again, very briefly, RARA break apart probe means normally what happens, this is your RARA gene. Okay, one probe binds to this part, which is 3', and another probe binds to this part, which is the 5'. So normally this 5' and 3' remains together, it will produce a fused signal like this. When there is a break and RARA gets rearranged, they separate to form separate green and orange signals. So these break apart probes are very useful in situations where this particular gene have multiple partners. So irrespective of the partner, break apart probes will be positive. Okay, so this fused signal is coming from normal RARA, and this separated orange and green signals are coming from the translocated RARA gene. So in a fusion fish, so there are fish can be of different types. So if you use PML RARA, fusion is abnormal. But if you use RARA break apart probe, fusion is normal, separation is abnormal. So we did RARA break apart probe, which showed 1 fused signal, 1 separate RARA, 5' and 3' signals. So this shows that this is an APML. This is negative for PML RARA, but it is positive for RARA rearrangement. So we had this ZBTB16 RARA probe, so we did it, and which showed 2 fusions. See this red and orange coming together and separate orange and red. So this is positive of ZBTB16 RARA rearrangement. So if it is also negative for this, we should go for a RNA-seq or RNA basically NGS, right? It is basically the routine NGS. We use DNA as a starting material. For identifying fusions, we have to start from the RNA. So if you use RNA sequencing, targeted RNA sequencing, we can identify the partner. So I have just summarized only few partners. There are so many other partners. I can say at least 25 to 30 partners are there for RARA. The commonest one, which is 95 to 97% is PML RARA. The next frequent is PLZF RARA. There are other partners like NPM, STAT5. It is very important to identify what is the partner, because PML RARA responds very good to ATRA, but PLZF RARA, there is no response to ATRA. We have to give chemotherapy. So the identification of this partner is very, very important to decide the therapy. Okay, so just
Arams.
right. So how to suspect a variant APML? One is an associated dysplasia. In routine classical PML RARA positive APMLs, usually we do not see neutrophils because the spontaneous differentiation is very uncommon. Even if we see, they are very, very rare. Okay, but in some of these variants, we get more neutrophils more frequently, and they often show dysplasia. We know that majority of the PML RARA positive APMLs, they're all abnormal promyelocytes. The classical blasts are very less, but if you see plenty of blasts along with promyelocyte, suspect variant APMLs. Now, suppose I showed you different kinds of morphology of abnormal promyelocyte, but if these abnormal cells are mimicking more of myelocytes than promyelocytes, suspect variant APML. If the nucleus is more regular than cleaved, again suspect variant APML. Abnormal crystal-like inclusions. In the beginning, I showed one case. I'll just quickly go to that case. If you see some crystals, there are crystals like this. This is one of our cases. You see crystals like this, suspect variant APML. So there are always morphological clues to suspect variant APMLs. You should be just cautious. Okay. And suppose in some situations, we morphologically suggest acute promyelocytic leukemia. The clinicians start on ATO ATRA, but then they feel that the response is not that great. So then again, if the response to ATO ATRA is poor, then again you have to suspect variant APML. So I'm stopping at this point, and again, I'm just highlighting the importance of morphology, the importance of clinical features, and the importance of a stepwise approach in reaching a definitive conclusion. Thank you, and I'm ready to take questions. Any doubt or any clarification required?
Thank you so much, sir. Sir, in the chat box, we don't have any new questions.
Okay. Right. Okay, I think if there are no questions, next, Karthik can take over.
Okay.
Yes, sir.
Then okay, I will just share my slides.
Sure, sir.
Okay. Are my slides visible?
Yes, sir. It is visible.
Yes.
Yes. Okay. Yeah. Fine. Okay. Let's get started. Okay. So let's go with case number 1. So it's a 60-year-old male, asymptomatic, master checkup, hemoglobin of 12, WBC of 50,000, platelets are normal. And this is a peripheral smear morphology. Okay. So who wants to describe the cell morphology? Dr. Ruchika?
Yes, sir. Sir, on
Yes.
peripheral blood smear, we are seeing, sir, numerous small mature lymphocytes. They are having clumped chromatin and
Okay,
scant
can you
cytoplasm.
have a better word to describe the chromatin pattern? You told clump. Is it uniformly clumped?
So opened
Or
up chromatin.
say, for example, some pale dark areas, like it's like a football. If you just imagine a football looks like a football, right?
Yes, a saucer ball.
Yes. So
Yes.
this is a typical football appearance. The football is not the
Football
round shape; it's the pattern. The pale and dark areas, pale and dark areas. Okay. So nice. This
So,
one, this one, this one. Right.
so
So
yes.
So what are your things which are coming to your mind just based on the clinical history and this morphology?
Sir, I'm able to appreciate some smudge cells also in the peripheral smear. So I made a
Okay.
differential of chronic lymphocytic leukemia, CLL.
Okay. Okay. Can this be an acute leukemia?
So,
Can this be an acute
so
leukemia?
No,
Mhm. Yes, Dr. Swati.
sir,
no, sir, it's not acute leukemia.
Okay. So based on history,
Based on
are there
history,
any?
its age is 60
Okay.
years, adult.
Okay.
Uh,
Okay. Okay. Because acute leukemias can happen in 6 years also, right? So what makes you think based on history it is not acute leukemia? Less likely. Nothing can be 100%, but less likely because the patient is asymptomatic. Usually acute leukemias commonly they present with symptoms, and then this patient just identified during a masteral checkup, so meaning that it was perfectly fine, just an incidental identification, right? Okay, fine. So 60-year male asymptomatic masteral checkup, we have some lymphocytosis, right? Okay, so this is a closer view of these cells. We can just still elicit the soccer ball appearance. Okay, now this is the flow plots which I gave you. Uh, so there are 82% viable cells in the peripheral blood. We are having some. These are 70% lymphocytes and around 30% your granulocytes are there. Okay, these are the plots which are shared, and these abnormal cells are in red color. And these among the lymphocytes, 77% cells are 19 positive and 5 positive. Okay, so this is the plots which I shared. Can someone describe, Dr. Mugilan?
Yes, sir.
Describe the flow pattern, like for the describe the expression for all these antigens
Yes,
for
sir.
this red population. Yeah.
Yes, sir. CD19 is bright positive, sir.
Okay, to use the term bright. Why you want to choose the term bright?
So it's towards the higher side. Dim.
Okay, we'll come back to that. Okay, fine. Okay, 19 is positive. Everyone agree that 19 is positive, right? Hello? Yes.
yes.
Okay, 19 is positive or negative?
Positive.
Positive. Okay, fine. So describe 5 expression.
Sir, 5 is also a positive, sir. Variable
Okay,
positive.
10. Okay, 10. CD10 expression.
So CD10 is negative, sir.
Okay. And CD20.
20 is
Right.
also dim positive, sir.
Okay, so in all these plots, the brown population will make T lymphocytes because they are 5 positive, 19 negative, and so this brown population may T lymphocytes and they're 43 positive. Okay, and by 20, this 20 is starting from 10, from the CD3, from T cell expression. T cells are usually 20 negative, right? And then just crossing beyond and reaching, not reaching up to a lot of B lymphocytes, but just touching. So it is negative to dim expression, right? And CD23 is positive or negative.
Yes, positive.
Okay, and so CD200.
CD200 is also positive, sir.
Okay, because in comparison to your internal control. Okay,
Yes, sir.
I just want to extract words from you so that I can just describe how to identify, describe the pattern of antigen expression by flow that we discuss. And then kappa and lambda in this population, red population.
It's a dim positive.
So it is negative. Okay, so it is just merging with the T lymphocytes. So it is negative. So, so what is the diagnosis for this patient? Dr. Sharwani, are you still driving?
Yes, sir. Sir, chronic
Okay.
lymphocytic leukemia.
Okay, fine. So do everyone agree with that?
Yes.
Okay, fine. So let's decode this. So this is a patient where we have done flow in peripheral blood in a patient with suspected CLL or any peripheral blood lymphocytosis. We did flow, and flow identified 70% lymphocytes, and common things common because it's just a peripheral blood lymphocytosis. It can still be a B cell disorder or T cell disorder. We don't know, but we usually commonly start with the B cell panel because CLL is more common and B cell lymphomas are more common. So we start with B cell panel. Okay, so we start and looking for any abnormalities in the B cells. So we start getting and seeing how are the B cells. So in this patient, B cells are 30%. So B cells, let's evaluate the B cells first. So how to identify B cells? What are the markers using which you can identify B cells in a sample? Yes, what are the markers? You know,
CD19,
Dr.
CD20.
Go ahead. T2019. Any other?
CD45
CD45 is not
is
for B cells.
leukocytic. Yes, sir.
Yes.
Leukocyte.
Okay. So any B cell lymphoma, any B cells, we have to identify them. We use something called gating markers or cells of interest because it should be expressed across all cells of that particular lineage. For B cell lineage, we can use CD19, 20, 22, 79A, etc. Okay. But we commonly prefer CD19 because it is a pan B cell antigen. It is always expressed across all stages of your B cell maturation. Okay. And it is rarely dimly expressed. Okay. So across almost all of the B cell lymphomas will be 19 positive, but the expression might vary. But CD20 can be a negative in certain high-grade B cell lymphomas also. And if patient is started with rituximab, CD20 expression can be negative to dim. Okay, so it is 20 might not be a good marker. And usually in CLL is a unique B cell lymphoproliferative neoplasm where you get, apart from CD19, almost all of the mature B cell markers will be having dim expression. Okay, so you never have a CLL which is having nice moderate expression of CD19 as we see in that of a normal B cell. Okay, so in the same case, the normal B cell is a blue population. However, the intensity of your expression of a CD20 will never reach to that of a normal B cell level. So always it will be dim expression. Like if you get a pattern like this, it is uniform homogeneous expression, you never come across this in a setting of CL. Okay. Similarly, CD22 also will be dimly expressed, sometimes can be negative also. But 19 is a marker which will never be downgraded. So, and most of the lymphomas, you will never get underexpression of CD19 except for follicular lymphoma, where you can have underexpression CD19. So, to identify B cells, you use 19, 22, 20, and of this, 19 is a common gating marker we use. So when we are dealing with the B cell neoplasm, first thing is to identify how many percentage of B cells are there, and straightforward, you have to identify whether the B cells are normal or abnormal. Because based on abnormal, if you call out normal abnormal, we can have multiple approaches. One is to identify the expression of aberrant antigens, or straight away you can look for the kappa lambda expression. Okay, versus clonality. So first thing is to look for whether the B cells are present or not, or how many B cells are there, and to identify the clone, whether the B cells are clonal or not. Okay, so is everyone with me? So identify the B cells and identify whether these are clonal just based on identifying the kappa and lambda expression on them. Okay, once you identify that these cells are clonal either because of kappa expression or isolated lambda expression, then you have to broadly categorize them into this based on the expression of 5 and 10. Okay, so this is a broad overview I'm giving. I'll just go step by step approach in subsequent slides. So first identify the B cells, then identify as a clonal or non-clonal, and then to broadly categorize, you can categorize them based on the expression of their 5 and 10, right? And once you do this, then you can use certain markers for subcategorization, like a big level list. But in flow, You cannot directly go and tell this is a this lymphoma, mantle cell lymphoma. We cannot have a single marker cannot give a perfect information. Okay, but apart from CLL or hairy cell and few other lymphomas, you cannot make a pinpoint diagnosis of categorization based on flow. But flow can give a good information as a clonal B cells or not, right? So we use gating marker and identify the B cells, and I access the clonality. Clonality expression based on the kappa lambda ratio. Two ways. One is the kappa lambda ratio. So kappa lambda ratio, normal kappa lambda ratio is 2:1. That is 2 times to 1 time. If 100 kappa positive B cells are there, 50 kappa positive lambda cells will be there. So if you get the B cells and look for kappa lambda expression, the ratio is 2:1, then it is polyclonal. The B cells are not abnormal, right? But when to clone monoclonal, if the ratio is skewed, either the ratio is more than 3:1, meaning that there are more than 3 times kappa positive cells and lambda positive cells, or less than 1:3, like more than 3 times more lambda positive cells. Okay, then we call it as monoclonal expression. So kappa lambda ratio 3:1 means more kappa cells, kappa lambda ratio 1:3 means more lambda cells. But the ratios were developed when there were flow cytometry was a bit primitive, gating markers were less. So ideally speaking, we cannot have a lymphoma having some cells which are kappa, some cells which are lambda. Rarely we can have composite lymphomas, but common things common. Either they will be completely restricted to kappa or completely restricted to lambda. Okay, so you have to always search for 100% expression. If you're not getting, then sometimes the ratios might help. Okay, so it is not always that the abnormal cells will be either a kappa or lambda or restricted alone. Sometimes you can have absence of kappa and lambda or co-positivity for kappa and lambda. Those things are all abnormalities which we can rely upon. Okay. So clonality based on kappa and lambda. So it can be nicely expressed, moderate expressed. Either here it is only kappa is there, lambda is not there in the population. Here it is a typical pattern which you see in CLL, where we have lambda restriction or a dim surface light chain expression, but it is very dim. So look at the kappa and lambda, the blue cells, these are normal B cells. So they are split into kappa and split into lambda. Okay. So our normal B cells will be split into kappa and lambda always. So kappa will be more. However, the subnormal cells are restricted to lambda, but the intensity is not reaching to the level of my normal B lymphocytes lambda expression. So the brown population by T cells, blue population by B cells, it is between those two. So it's a dim lambda expression. Commonly, your CLLs will have dim expression for kappa or lambda, or it can be negative. Like this is our case, it can be negative also. Clear? Any doubts? So identify the B cells, identify the clonality based on restricted expression of either kappa or lambda, which can be moderate or it can be dim, or both can be negative also. Okay, so now all these scenarios indicate that the B cells which are identifying are clonal. Okay, so once you are knowing that the B cells are clonal, then you have to look for your combination of 5 and 10. Right. This is a case where we are having 5 expression, heterogeneous expression, and 10 is negative. So how I call 10 negative? The green population are my neutrophils. Neutrophils is my internal control, and the brown population are my T lymphocytes. Will T lymphocytes express CD10? Dr. Swati?
Yes, sir.
Will T cells express CD10?
Yes, sir.
No. Normal T cells will not express CD10, so that we take it as an internal control. So neutrophils will be CD10 positive. So the expression of CD10 in my abnormal cells is similar to the pattern seen in my T cells. So it is CD10 negative, but CD5 is positive. So we are dealing with the CD5 positive malignancy. So for all B cell lymphomas, we can just broadly put into these baskets of combination of 5 positive, 10 negative, 5 negative, 10 positive, dual negative, or dual positive. The common B cell lymphomas we encounter are 5 positive, 10 negative ones, among which the commonly we do flow cytometry we encounter in the CLLs or mantle cell lymphomas. Right. So this table you should be thorough. This is a very good publication from Fiona Craig, published in Blood, where they describe this thing very nicely, and this is a nutshell. So 5 positive, 10 negative lymphomas, CLL mantle, which we commonly encounter, we have to differentiate both these entities because both the 5 positive and both the clinical behavior is very different, right? And 10 positive lymphomas, these are all follicular center lymphomas, right? So what are follicular center lymphomas? You have follicular lymphoma, DLBCL, Burkitt's, and rarely you can have hairy cells. Very rare. Usually hairy cell leukemia is 5 negative, 10 negative. Okay. So now our case we are dealing with 5 positive, 10 negative. So common differentials, most common based on the clinical scenarios, chronic lymphocytic leukemia, plus mantle cell lymphomas, they will be having aggressive presentation. Okay. So what is MATUTE score? So as we previously described, there's not a single marker which will pinpoint to an exact diagnosis of a leukemia or lymphoma. It's a combination of markers. So MATUTE score is the one which was initially followed. Like we look for the expression of CD5. If CD5 is negative dim expression, it's called, they give 1 point. If CD23 is positive, we give 1 point. And if 57 negative, we give 1 point. If surface immunoglobulin, it is negative or weak, we give 1 point. And 22 or 79 bits, weak or negative, we give 1 point. You see, in most of the scoring systems, if something is expressed or positive, we give a positive score. Here, it is interesting to see that if something is negative, we give a positive score. Okay, this is the original MATUTES where we look for 5, 23, FMC7, surface immunoglobulin M, or CD22 or 79B. If we give scoring and the score is 4 to 5, we call it as CLL. If it is less than 2, we call it as non-CLL straight away. So this is original MATUTES, this is modified MATUTES. In modified MATUTES, instead of 22 or 79B, people started using 200. So if 200 is positive, we give 1 score. Clear? So Dr. Ruchika, what are all the components of modified MATUTES?
So CD5, CD23, and CD200.
Okay. And 2 more? FMC7, surface immunoglobulin. So 5 should be positive, 23 should be positive to get a score of 1. FMC7 should be negative. Surface immunoglobulin can be negative to dim. It can be negative also. Then if these two are negative, give a positive score. And 200 is positive, then give a positive score. Right? This 223, no one still, now the scoring systems are more evolving. Still people are doing diagnosing CLLs even with 323. Okay. So MATUTES is not still followed, but still you can follow it. Right. Now, why so? What is so special about CD200? CD200 is expressed in hematogones and mature. What are hematogones, by the way, Dr. Mugilan? Dr. Mugilan? Okay, Dr. Swati, what are hematogones? So can you hear me? Am I audible?
Yes, sir, you're audible.
Okay, fine. So hematogones are B cell precursors which are present in the bone marrow. So CD200 is normally expressed in hematogones or mature B cells. Negativity or bright homogeneous positivity is considered abnormal. Okay, so these are my mature B cells can express CD200 but to a dim level, and hematogones can also express CD200 to a dim level, right? So CD43. So in 200, as in CLL, 200 will be nicely positive. So tell me, other hematological malignancies where 200 is positive? Dr. Sharvani? Sharvani? Right? Any one of you can answer. What are the other hematological malignancies, be lymphomas, where 200 can be brightly expressed?
Hairy cell leukemia.
Yes, hairy cell leukemia. Yes, hairy cell leukemia can be 200 brightly positive, and you say CLL with another leukemia is another CLPD where 200 expression can be moderate. Okay. So CD43 is one more marker. It's considered it is similar to CD45. It is also considered as a pan-hematopoietic marker where expression almost all hematopoietic lineage cells except B cells. So B cells, normal B cells will be CD43 negative. So we make use of this antigen in combination with CD200 to identify CLL2 versus mantle, right? So when we look for expression of among CD5 positive B cell PDs, you look for CD43 and 200 expression. Okay, if both of your mantle cell lymphoma and your CLLs will be 43 positive. Okay, and 200 will be negative in your mantle cell lymphoma and positive in your CLL. So just based on these two marker combination, you can dissect between your mantle cell lymphoma and your CLL. So this is a pattern which we see in chronic lymphocytic leukemia. So this is our case. 19 is nicely expressed, CD5 is positive, 10 negative, and these cells are clonal because of absence of both kappa and lambda, and 20 is dim, and 10 is negative, and 200 is nicely positive, and 43 is also positive. So with these markers, even without CD23, but in this case we also did CD23, even with CD23 we can make a diagnosis of chronic lymphocytic leukemia, right? So what is the pattern in this case? So Dr. Ruchika, who is CD19
Yes.
expression? 19 positive or negative?
CD19 positive.
Yeah. Okay. And CD5?
So CD5 is
Five?
also
Yeah.
positive.
Negative to dim expression, right? And CD20?
CD20 is positive.
Positive. As compared to this one, can I what is the difference? So it is not lying inside the box. It is not reaching till the level of my normal B cell. But here it is nicely reaching to the level of normal B cell. So both are positive, but the intensity is nicely positive or moderate level, or reaching up to the level of my normal B cell lymphocyte here, right?
Yes.
And kappa lambda expression, is it having restriction or not restriction? Is clonal or non-clonal?
Restriction, so kappa restriction.
Kappa. Yes, kappa restriction. And look at the intensity of kappa expression. So it is reaching up to the level of my normal B lymphocyte. So it's moderate expression. And CD43?
Positive.
Positive, negative dim expression. CD200?
CD200 negative.
Yes. Okay, so what is this case?
CD19.
Okay, 19 positive, it's a B cell, and we have identified as clonal based on kappa lambda expression. So clonal B cells, then you have to look for your 5 and 10. So 5, because you have to categorize into those 5, 10 categories, right? So this case will fall in the basket of 5 positive, 10 negative, right?
Negative.
Yeah. So you agree or not agree?
Yes, sir. 5 positive, 10.
So 5 positive, 10 negative, what are the two common DDs?
So 5 positive, 10.
Nana?
CLL.
I know you are all hungry and sleepy, but you have to cooperate with me for another 20 minutes. Right. Okay. So two things. 5 positive malignancies or more. Yes. So how you differentiate CLL and mantle? Just tell me, give me one marker. CD200. CD200 will be positive in your hairy cell leukemia and negative in your mantle cell lymphoma, right? So both are 5 positive. This is the most common differentials when you come across flow in a B cell lymphomas, right? B cell malignancy. So 5 positive negative malignancy, look for your 200 expression, which is negative. It is mantle cell lymphoma. And other features which will help for your hairy cell leukemia, chronic lymphocytic leukemia, or your dim expression of your mature B cell markers like CD20, 22, and negativity or dim positivity for kappa and lambda, right? Clear? Any doubts? Okay. So is bone marrow required for diagnosing CLL?
No.
Okay, good. Right. Yes, bone marrow is not needed. So if you want to do, once you diagnose a case of, what is the diagnostic criteria for chronic lymphocytic leukemia? If you're having
more than 5 into 10 to the power 9 cells per liter.
What is 10 to the power? It is just give me a round number, man. 10 to the power
So
9
more than 5
per microliter or per liter, per deciliter?
Per liter, sir.
So it is 5,000 cells per microliter. Okay. So 5,000 cells means what do you want? What do you mean by 5,000 cells? If the TLC is more than 5,000, will it qualify for CLL?
Clonal B cells.
Yes, Dr. Miguel, you're telling something? Tell me.
I said clonal B cells.
Yes, clonal B cells. Yes. So even if you're having tons and tons of your lymphocytes in peripheral blood, you have to do flow and identify the percentage of clonal plasma, clonal B cells. If that clonal B cells are exceeding more than 5,000, then only it qualifies for your chronic lymphocytic leukemia. Okay. If it is less than 5,000, what is it called? Yes, Dr. Swati. If the clonal B cells in circulation are less than 5,000, what is it called? It's called monoclonal B cell. Yes, monoclonal B cell lymphocytosis. Yeah. Yes. So clear? So once you so peripheral blood is sufficient to make a diagnosis of your chronic lymphocytic leukemia. Even if you want to do FISH, you can do it from peripheral blood. Marrow is not bone marrow is not mandatory, right? Okay. So the International Working Group CLL guidelines has clearly mentioned that sorry, immunophenotyping is the in peripheral blood is the morality, and bone marrow aspirate only under certain sorry. Only under certain conditions, like the patient of Harris CLL is having cytopenia, marked severe anemia. Anemia is not commonly presentation for a CLL, and because these patients can have underlying PRC, okay, or aplastic. So those conditions we can evaluate only if we do a bone marrow biopsy. Then versus only few subtle indications by doing bone marrow biopsy or bone marrow aspiration and CLL. Otherwise, CLL you can diagnose with the peripheral blood itself, and you prognosticate in based on FISH, those on peripheral blood itself. Yeah. So let's move to the second case. Any doubts? Okay. So case 2, 6-year-old male, sudden onset dyspnea, hemoglobin 4, WBC of 90,000, platelets are 23,000. So Dr. Swati, based on the clinical history, what is coming to your mind? The child having some
AML.
Yes.
AML.
Why AML?
Age is 6 years.
Okay.
Then anemia, leukocytosis, and platelet count, thrombocytopenia.
Okay.
Pancytopenia.
It's not it's bicytopenia. So why you want to call it as AML? Why can't be ALL?
No, sir.
Yeah, think of acute leukemia, the sudden presentation, and 6-year child. Sudden, it's not as if I saw in previous kids. It was not a patient went for mastocytal checkup. It's an incidental finding, asymptomatic. Here we're having some patient with sudden onset dyspnea, something acute, and then the counts are very haywire. We have bicytopenia, anemia is very bad anemia, and platelets are also very low, and we're having leukocytosis. So it's a short presentation, drastic presentation. So your first word you started is acute leukemia. Don't tell acute myeloid leukemia, acute lymphoblastic leukemia just based on clinical history. Concerning history like bleeding, gums, those things are soft pointers. Because if a APML patient, the patient is coming in your emergency with the bleeding, then you have to think about APML first and your monocytic leukemias. Okay, but those are still soft pointers. We can also have bleeding manifestation in ALLs also. Okay, those are certain clinical soft pointers. For exam point of view, if given a clinical history like this, and the examiner tells that the patient is coming with bleeding, then first thing should coming to your mind is your APML, right? Otherwise, if that history is not provided in exam purpose, then you just stick on to acute leukemia, right? So this is a morphology in the peripheral. Okay, so how are these cells as compared to the previous case morphology? What is the difference in the morphology you see in this case, Dr. Ruchika?
So here we are having a high NC ratio.
Okay,
And
size of the cells?
So they are 2 times the size of the RBC, 1.5 to 2 times the size of.
Okay, you used RBC as a comparator, size comparator?
Lymphocyte,
Yes.
sorry, sir, lymphocyte,
Yes.
small mature
Dr.
lymphocyte.
Dr. Pooja is your teacher, right? Pooja Murgai, ma'am?
Yes.
Yes. Okay. I'll not
And
tell her. Don't worry.
the chromatin
Ah, mm.
is
Yeah,
opened up
this is a
chromatin,
lymphocyte. Yes.
lymphocyte.
This is a lymphocyte. And comparison to this,
Yes,
you
sir.
can easily stuff around 3 lymphocytes in this cell and 2 in this cell. So there's a heterogeneity in size. These atypical cells or blasts are 1.5 or 2 to 3 times the size of a mature lymphocyte. And
A
they have,
lymphocyte.
yes, and they have a high NC ratio. So because cytoplasm is scanty, we got high NC ratio. And then the nucleus borders are regular membrane. Regular borders.
Yes.
Chromatin is clumped or opened up.
So opened up chromatin.
Yes. As you compare to a mature lymphocyte, the chromatin is opened up.
Opened up chromatin.
Right? And do you have any nucleoli or something? No.
So
You're not having any nucleoli. Yes. And cytoplasm, is it having any granules?
No, sir. No granules.
No granules. Any oil rods?
No oil rods.
And then the color of cytoplasm? Pale basophilic. Yes, pale basophilic. So the blasts are 1.5 or 2 to 3 times the size of a mature lymphocyte. The nuclei have regular membrane, opened up chromatin. So if there is nucleoli, you just need to mention the nucleoli. Then cytoplasm is scanty, pale basophilic, agranular, and no oil rods. This is a typical description. Because I'm more convinced towards blasts because the chromatin is more opened up and based on the clinical history.
Yes.
Still, I will not. Okay. Do you want to call it as AML or ALL? You want to commit?
So ALL.
ALL.
Lymphoblasts. So these are lymphoblasts.
Okay. So what is AML M0? Minimal differentiated acute myeloid leukemia.
Minimal. Yes, sir.
So okay. Still acute leukemia. Don't
acute
utter
leukemia.
any word. Don't commit to any lineage.
Yes.
Okay. In exams, yes, most likely ALL, but I cannot rule out AML, M0, those sort of things. Okay. So acute leukemia is a safe bet to go. Right. So the red population is the cells of interest. So before going to this, I just want to describe how we identify intensive antigen expression. So you all come across the words like dim, moderate, negative, bright. So what does it mean? Okay. Say for example, we'll take any antigen. Say for example, CD38. Okay. So CD38, for each antigen, you should be knowing which are the normal internal positive control, internal negative control. So CD38 will be negative in your red blood cells, RBCs. Okay. And CD38 will be brightly expressed in your plasma cells. So RBC intensity is 0. It is having 4 log excess of expression of intensity of CD38. Right. This is called bright expression. Next comes your hematogones or your monocytes. Those sort of cells will be having 38 moderate expression. And neutrophils will be having expression between your negative cells and your moderate cells. It's called dim expression, right? So if you have a control, positive control, negative control within the tube, right? Therefore, CD38 hematogones are termed moderate, plasma cells are bright, neutrophils are dim, and plasma and your RBCs are negative. So anything which lies between your RBC and hematogone is called a dim expression. Okay, you got this clear? Dr. Mugilan? Dr. Shwati?
Yes.
Yeah. Okay, you got this, right? So how to express, describe antigen expression. Okay. Now, if a blast is having a 38 expression as good as my red blood cells, so it's called negative.
Negative.
Right? And if a blast is having expression spanning from the expression seen in red blood cells, which is negative, up to the level seen in neutrophils, negative to dim. Okay, it's not reaching up to the level of hematogones. Reaching up to the level of hematogones is called as moderate. Okay, and here the blasts or cells of interest are having expression of intensity as good as my neutrophils, but it's not overlapping with my red blood cells or my hematogones. So this is called dim expression. So it is negative to dim, it is dim. Right? Here it is spanning from neutrophil expression to that seen in your hematogones, dim to moderate. Fine. And here it is as good as seen in my hematogones. So moderate expression. If it's expressing the antigen intensity is as good as my plasma, it's called bright expression. So based on internal comparator, you call the described expression as dim, moderate, bright, heterogeneous, those sort of things. Clear? Is this concept clear? If any flow plot is given, you have to interpret this way with the internal control. Okay. So with this in mind, now Dr. Swati will interpret this flow plots. Dr. Swati, the red population cells of interest. So what is CD45 expression?
Positive.
Yeah, positive. The intensity wise. So here the blue population are my lymphocytes, black population are my debris or red blood cells. So this is negative, this is moderate. So what is the expression of CD45?
Moderate.
Dim. ये दोनों के बीच में है, फाइन. ये मॉडरेट है, ये नेगेटिव है, दोनों के बीच में. दिस इज कॉल्ड डिम एक्सप्रेशन. ओके. एंड CD19 is positive or negative? Because the blue population are main. Yes, tell me.
19 is positive.
Positive, yes. 79A?
79A is also positive.
Positive. Range intensity negative to moderate. Right. And CD22?
22 negative.
No.
Dim positive.
Dim positive, yes. The brown population, because I am following this color code in my lab. So this brown population is T cells and the blue lots are my B cells. दोनों को बीच में है, so it is dim expression, right? Right. And then coming to markers of immaturity, 34 is negative, and yeah, and 10 is
10 is positive.
Positive, yeah. And CD20?
CD20 is dim positive.
Heterogeneous positivity, right? So negative to moderate. Sorry, negative to dim expression, heterogeneous. Okay. And so 58 is nicely positive. So what is your diagnosis? In this case, a 6-year-old child having acute manifestation and is having blast, and we are having B lineage markers. Dr. Mugilan?
ALL.
Yes, which ALL now? TLL?
No, sir.
Yes.
B cell.
It's a B cell ALL. Yeah. Okay, got it? Because we are having B cell markers. So diagnosis is BALL. Okay, based on the karyotype figure given here, what is the recurrent genetic abnormality present? Yes, Dr. Swati or Dr. Ruchika. What is the recurrent genetic abnormality?
Hyperdiploidy. We can see hyperdiploidy.
Why you call hyperdiploidy?
So more than 50 chromosomes, 57 chromosomes are there.
Okay, so if it is 67 chromosomes, 65 chromosomes, you will call it as hyperdiploidy?
Yes, sir.
Okay, if it is 66 chromosome or 67 chromosome, you got a hyperdiploidy?
Yes, sir. More than 50 chromosomes, we can
More than 50.
hyperdiploid.
Okay, so why you want to know whether it's hyperdiploid or non-hyperdiploid? Because it's having prognostic relevance, right?
Prognostic factor.
Okay, but now, as you just told, more than all model chromosomes more than 50 is not hyperdiploidy. Okay, so high hyperdiploidy is the one 51 to 65. Okay, it's called high hyperdiploidy. This is the one which is having prognostic relevance. It's literally having good prognosis. Okay, intermittent prognosis. So if it is 67 chromosomes, it is near triploid. Near triploid is a poor prognostic thing, and is almost always associated with your low hypodiploidy. Right. So remember that not all the chromosome numbers more than 50 are hyperdiploid. Yes, they are hyperdiploid, but high hyperdiploidy. 51 to 61 is the one which is to be labeled as high hyperdiploidy. It is 57, yes, is high hyperdiploid. 66, it is not high hyperdiploid, it is near triploid. Okay, so you should be remembering this cutoff. So 51 to 65 is the one is having a better prognostic relevance. Okay, so the magic number is 51 to 65. Clear? So this patient
Yes.
will fall under high hyperdiploid.
High hyperdiploid.
Yes. Right. So these are the recurrent genetic abnormalities which are being discussed in WHO. So high hyperdiploidy, hypodiploidy, and these are all the recurrent genetic abnormalities which are all based on the fusions. Right. Like IM20, it's not fusion, like BCR-ABL, ATVRNX1, TCF3PBX1. These are all the ones which are having which are to be identified because each is having a relevant prognostic information or therapeutic relevance. Okay, and in current WHO, these are the provisional entities which are included, which we have to identify. Okay, so if any case of BALL you are diagnosing, by flow will give you the lineage-wise identification. It will classify and tell it's a BALL. Morphology-wise, you cannot tell it is a BTML or something. So you do flow. Flow will give you whether it's BT or myeloid. Okay. So once you identify it as a BALL, we have to assess for all these recurrent genetic abnormalities. Okay. So for that, you have to do your assessment properly. Molecular assessment is definitely required. If you are done assessed for all these entities, if all these entities are negative, then you call it as BALL NOS. NOS means not otherwise specific. Okay, but if you are not assessed for any of these entities or you've done only partial evaluation, then you term it as BALL NFC, not further classified. Okay, this term NFC has been introduced in current WHO, not what was not there in previous WHO. So if any BALL patient you are diagnosing, you have to do flow. After flow you have done, then you have to identify these recurrent genetic abnormalities either by FISH or cytogenetics, conventional karyotyping, or by molecular techniques. If you are not done that evaluation for either of these entities, for any of these entities, then you cannot call BALL as BALL-NOS. You should call it as BALL-NFC. In India, most of us don't work up for these things. Okay, only few labs done. So most of us will end up in diagnosing BALL-NFC. Okay, clear? You know that now you understand the difference between NOS and NFC, right? Any doubts? Right. So just now we discussed. Okay, so how to assess lineage commitment? So any acute lymphoblastic leukemia or acute leukemia will have dim CD45 expression. Okay, CD45 expression will be dim, and you have to then further assess for lineage. So lineage assessment for B lineage, you look for CD19, CD79A, and CD22. So this case is positive for CD19, CD79A, and 22. So B lineage orientation is there. In this case, is negative for MPO. And cytoplasm CD3 was also negative. I think I have not shown the plot. So CD45 dim cell, yes. CD45 dim cell, which is positive for B cell antigens, like CD19, CD17A, and CD22 means it is having a B lineage commitment. Then you have to assess immaturity. So presence of CD34 indicates that these cells are immature, and CD10 will be brightly expressed in an immature B cell, and 20 will not be expressed in a normal mature B cell. 20 will be bright, having moderate expression, but these cells are having a dim expression. So not expressing CD20 is also considered as immaturity, right? 34 is negative, 10 positive, and 20 is heterogeneous, dim expression. Yeah, it is considered as immaturity. Okay, so then you can do further use of certain other discriminatory markers, like certain markers which will be present in your leukemic B cells, absent in your hematogones and all. So one such marker is CD58. We don't need to remember this. This list is a big list. Okay, just need to know how to approach. So identify your CD45 dimness and assess the lineage. And once you assess the lineage, then you have to assess for immaturity and look for certain discriminatory markers. This is how you diagnose a BAL. Right? Clear? Any doubts? Okay, so next case. So similarly, 6-year-old male, sudden onset dyspnea, hemoglobin is 4, WBC is 90,000, platelets are 23,000. This is the karyotype. Okay, Dr. Ruchika.
Yes, sir.
And this patient is also a BALL. Okay.
Yes, sir.
And this is the karyotyping. Okay. What is this karyotyping? Is there anything abnormal?
Sir, no, sir.
Yes, it's called the XY chromosome. Yeah. So do you think there can be some abnormality which is still present in this case?
So genetic no, fusions.
Okay, this is a limitation of your conventional karyotyping, because in conventional karyotyping you're just eyeballing. You just visually you are seeing. Okay, certain things can happen beyond your visual interpretation. These are called as cryptic genetic abnormalities. Okay, so but in this karyotyping, it is polycystic XY, it is normal, right? So this is again, can you just the red population per cells of interest? What is this case? It is a BAL I already discussed. So for want of time, I'm not going further. And this is the fish done in this case. Okay, this is a probe used for ETV RunX. ETV is in green and RunX1 signals are in red. Okay, so what is your diagnosis? What is the recurrent genetic abnormality?
Sir, here we can see that there is deletion of ETV6 in the ETV6 deletion RunX fusion, sir. ETV6 in RunX fusion.
What do you call ETV6 deletion?
ETV.
ETV sequence are in green, right?
Fusion positive.
Fusion hospital. That's a fusion.
Sir, you are not audible.
Can you hear me?
No, sir.
Can you hear me now? No.
Karthik, your voice is not clear. Karthik.
Oh, one second. I think some net disturbance. 1 second.
Yeah, I think your voice got just little.
Okay, one second. 1 second. Hello, can you hear me now?
Yeah, it's better.
Fine, sir. Just some disturbance out there. So the green signals are your ETV6 and the red signals are your RunX1. Okay. So normally you should have two ETV signals. So ETV is in which chromosome? ETV is in chromosome 12.
12.
Yeah. Okay. So this represents that two normal ETV6 are present. They're far apart. Okay. And here you're having cluster of signals of RunX1. Okay. I repeat, it's a cluster of signals. So the same, this is a metaphase. In the metaphase, we apply fish probe and you see the two discrete ETV signals representing chromosome 12 are present separately. And there's a clustering of these RunX1 signals on a chromosome, right? This is aimed out. So this is what entity? Amplified. These RunX1 signals are amplified.
Amplified.
Yes. So what entity it is? It's a recurrent genetic abnormality seen usually in pediatric BALLs having a poor prognosis.
Yes.
So is this intrachromosomal amplification of chromosome 21. So you'll be having clustering of these ETV RunX1 signals together. If you will never get a clustering of the signals, if you are never getting clustering of the signals in a fish probe for RunX1, it is called IAM21. Clear? Okay, there is some specialty or very usefulness of this probe. So using this ETV RunX1 probe, what are all genetic abnormalities you can identify? Yes, someone called fusion, right? I think Dr. Swati told it is fusion.
Yes, sir.
Right? Yes, because is it you can identify ETV annexon fusion. Same probe, if there's no fusion, if there's a pattern wise, we're getting this clustering pattern, is called annexon amplification or IAM21. And chromosome 21 is one of the commonest chromosomes involved in your hyperdiploidy. Okay, so if you see this hyperdiploidy patient, there are plenty of chromosome 21, there are 4 chromosomes of 21. Okay, the chromosome 21 is one of the commonest chromosomes involved in your hyperdiploidy. So RUNX1 signals, RUNX1 is present in chromosome 21, right? So if you're getting more than 2 signals of your RUNX1, it indicates there is more increased number of your RUNX1 signals or chromosome 21. So it indirectly means there's an underlying hyperdiploidy. So based on one probe, ETV RUNX1 dual fusion probe, you can identify hyperdiploidy if there are more than 2 number of your RUNX1 signals. If the clustering of RUNX1 signals, it is IAM21. And if there are 2 fusions, you are identifying ETV RUNX1. So one probe, it can give a good prognostic parameter, one bad prognostic parameter, and almost one good prognostic parameter. So this is a specialty of this, right? Any doubts?
No.
So I'm not going into detail about this probe interpretation because it will be taken in some other class. So this is the special. Yes, sir.
Yeah, we lost you in between. Again, you're back. In between, your voice goes. Now you're back. Now, fine. It's fine.
Okay. Thanks. Specialty of this probe. So one probe, multiple information. So case number 4. So identify the ploidy in this case of BALL. So the red peaks are my blast and the blue peak are my lymphocyte. So this is called, so just now we discussed ploidy can be assessed by your conventional karyotyping where you just count the number of chromosomes. Okay, we just count 51 to 65, it is high hyperdiploidy. Okay, this is another way of doing ploidy where you do something by flow cytometry called DNA index. Okay, and you can do ploidy. So identify the ploidy. Have you come across this terminology? If you don't know, don't worry, we'll just discuss. Can anyone want to attempt? Dr. Mugilan? Right. Dr. Shadwani? Dr. Shwati?
Hyperdiploidy.
Okay, hyperdiploidy. Okay, this also sort of correct. So, okay, let's see. So, I'll briefly discuss the concept of DNA index. So, when a cell goes in a cell cycle, like normally cells will be in G0 phase or G1 phase. Like most of the cells in the body will be in the quiescent phase or G0 phase. Or cells like the active living cells like a hair follicle, G epithelium or hematopoietic cells will be under constant turnover so that they will be entering the cell cycle frequently. So this is physiological. So in G1, when cells go from G0 phase to G1 phase, there will be increase in the ribosome and the RNA and protein machinery, which pushes the cell towards your DNA replication. Okay. So yeah, there will be increase in your RNA content in G1 phase. And there will be no increase in DNA content. And in the S phase, you'll be having actual duplication of your DNA content. Actual replication happens here. And in G2 phase, it's a checkpoint where the checkpoint, the machinery looks for any other abnormalities, mutation which are irreparable or repairable. If it is repairable, it will be repaired. If it's irreparable, then cells will get apoptosed. Then the actual mitosis, which you see in pictures like your chromatin separate, those things happen. Okay, this is a typical cell cycle. So as the cell cycle grows, the DNA index, the amount of DNA increases. Okay, so if you take a fluorescent dye, which can specifically go and bind to the DNA, then you can identify the amount of dye binding to a cell is equivalent to the amount of the DNA content in the cell. It's a very simple concept. So the DNA content in a cell is equivalent to the ploidy of a cell. Say a cell is having 46 chromosomes and each chromosome, say for example, is taking one dye, just a representation. So if there is 46 dye molecules there, it is diploid. If a cell is having if a cell is having around more chromosomes, so 46 into 2 times of then you will be having 2 times the higher number of your DNA, your dye content. Okay, so if you have any mechanism to identify it, then you have to compare the DNA content of your blast cell divided by the DNA content of your lymphocytes, because lymphocytes are your long-lived cells. They are almost always diploid. Their nuclear content will always have 46 chromosomes. Okay, so you identify the DNA content of the G1 phase of your blast, which is determined by the geometric mean or the MFI of the amount. This geometric mean MFI is identify the intensity, right? Equivalent to the amount of the dye present in that. Okay, so G1 phase DNA content divided by G1 phase of a lymphocyte DNA content. So it is 275 divided by 260. The ratio is almost 1. This 1:1, right? So it is a diploid. So 46 chromosomes in both. So the index is 1.05. So we can have equivalence for the model number of chromosomes with the DNA index. So if the DNA index is 0.96 to 1.05, it is diploid. If the DNA index is 1.16 to 1.39, it is corresponding to 51 to 65 chromosomes. So whenever in a BALL patient, you are encountering a DNA index of 1.16 to 1.39, it is almost equivalent to your high haploidy identified by your conventional karyotyping, right? So the magic number is more than 1.16 and the upper limit is 1.39. So what is the model chromosomes to define high hyperdiploidy, Dr. Ruchika?
Sorry, sir.
What is the model number of chromosomes to define high hyperdiploidy by
Sir,
karyotyping?
51 to 65.
Yes, the upper limit is 65, 51 to 65. The same corresponding by flow, DNA index is 1.16 to 1.39. Okay?
1.39.
1.16 to 1.39. So now you understood the concept of your DNA index, right? So it's a
Yes.
DNA content in the G1 phase of your blast divided by the DNA content in the G1 phase of your lymphocyte. Say this is the overlap we are seeing. So here the DNA content is 336 in the G1 phase of my blast. Here it is 282. If you divide 336 by 282, it is 1.18. It is high hyperdiploid. Simple.
Yeah.
So it can even identify hypodiploidy also. So DNA content of my blast is G0, G1 phase is 207 divided by 219. So visually you are already seeing that the DNA content is lesser than my normal DNA content in my lymphocyte. So 207 divided by 219 is 0.94. It contains to high hypodiploidy. And this is the case which we had discussed. We put up in the questionnaire. So the DNA content is 340 and the lymphocyte DNA content is 232. The ratio is 1.46. So it is near triploid. Clear? Now you got the idea of what is DNA index, right? We need not memorize all these numbers. Just one number to remember, 1.16 to 1.39. If the DNA index is in this range, we call it as high hyperdiploidy, right? Clear? Any doubts? Okay. Now going to the last case. So again, it's a 3-year-old male, Sarnot dyspnea. HB is low, WBC is 80,000, platelets are 23,000, and cytochemistry MPO is negative. So these are all blasts. Everyone agree with me?
Yes.
Yeah. These blasts are having nuclearia also, right? So do you want to commit to as AML or ALL?
ALL.
AML?
ALL.
ALL. Why ALL? So always don't commit to any lineage, okay? Always commit to acute leukemia. Because by common conventional description will tell that nuclear will be prominently seen in your AMLs, those things and all, okay? But so don't go by that. By morphology, you can commit only acute leukemia, okay? You cannot pinpoint the lineage, except for your APML where you're having pathognomic molecular features, morphological features. There are no pathognomic morphological features for acute leukemias other than APMLs. So simply calling it as acute leukemia, it is better, right? Okay. Now, Dr. Ruchika.
Yes, sir.
So yes, what is CD45 expression? Correct.
So CD
For CD45,
45,
yes, in blast, yes, yes.
sir, it's positive.
Positive, and the level of expression is below my level of my internal positive control, which is my lymphocyte. So it is dim expression, right?
Dim.
Yeah, dim. With reaching here, it is moderate. It's reaching, it's thoda piche. So it is dim expression. Yes. Okay. And CD45 will be dim expression here, neutrophils, almost same where neutrophil. CD7 expression?
Sir, it's positive.
Positive, and more than my normal T cell expression, so it is called bright positive. Agree?
Right, positive.
Right. And surface CD3 is negative.
Yes.
Okay, 7 positive and surface CD3 negative. And this is cytoplasmic CD3.
Cytoplasmic CD3, it's positive, sir.
Yes.
Moderate.
Agree. Moderate expression. Yes, I agree. MPO is positive or negative?
Negative.
Yes, agree. So you're having a cell which is 45 dim. In dim indicates it is a bit of immature. And then cytoplasmic CD3 positive. So it is which commitment? B lineage, T lineage, or myeloid lineage?
T
Yes.
cell.
Yes, cytoplasmic CD3 almost is a signature for your T lineage commitment, and your CD7 will almost always positive in your TALs. You will never encounter a TAL which is 7 negative, right?
Yeah.
Okay, what is 4 and 8 expression?
So 4 and 8 positive. Positive.
On the
4
blast
and
in the blade. 4. What is okay? What is 4 expression? This is my normal internal control for 4. This is negative.
Negative.
Yeah, this is for
8
8
is
expression.
also negative.
Negative. So it is a bone marrow. Even without looking for the sample with is a bone marrow peripheral blood, I can just because okay, what will the 4 and 8 ratio in your peripheral blood? Which will be more?
So CD4 cells.
Yes, yes. But in bone marrow, the scenario is reverse. Because whenever you're getting in the peripheral blood, if you're getting more 8 positive cells than 4 positive cells, you want to look for your HIV, those infection, those workup and all. Okay, you'll be alarmed and look for. But in bone marrow, we'll be having 8 positive cells will be more, that is normal. Okay. Okay, fine. So these cells are 4 negative and 8 negative. And CD1A?
So CD1A negative.
Yes. And CD56?
So CD56 also negative.
Yes, correct. And CD34? This is my normal internal negative control. Yes. 34?
Positive. 34 positive.
117?
Right. 117 also positive, so bright
Positive.
positive.
So you're having a T lineage oriented cell which is positive for your 34 and 117, which are myeloid lineage antigens, or 34 is immaturity antigens, 117 is a myeloid lineage antigen, right?
Yes.
Okay, so what is and this is your CD5 expression. What is CD5 expression?
CD5 is positive.
No, CD5 here is an x-axis. CD5 expression is?
CD7 positive, CD5.
Yeah. Yes, go ahead. Yes, agree. So, what is your diagnosis in this case?
Sir, precursor T cell ALL.
Okay. Can you refine it further? Want to base any subtype in T lineage ALL? Okay, let's go. So, no problem. Yeah, that's what. let's see. So, having cytoplasmic surface CD3 expression is a pathognomic for T lineage. So, in older WHOs, we used to call it as pro-T, pre-T, cortical, and medullary based on the expression of this 7, 2, and CD34 and all. Okay. So, but this concept is not existing now. Okay, whatever which were called as pro-T and pre-T are either clubbed into the ETPL category because any of the T lineage ALLs based if they are 1A negative and 4 and 8 negative and express immaturity antigen 34 or minor antigens, they will be going into either of your ETPL or TALL, which we'll be discussing now. This is according to current WHO TALL subtypes. TALL NOS, ETPLL or near ETPLL. Okay. Now, these are the diagnostic criteria. For ETPLL, cytoplasmic or surface CD3 must be positive to have a tail end orientation. And the myeloperoxidase should be absent. As we discussed in our case also, MPO and absent. And CD1A and 8 should be absent. And more than 25% of blast should have more than one of stem cell or myeloid markers like 34, 117. In our case, we had 34 and 117. Apart from that, we have learned for 13, 33 or HLDR, so on. And we have negative to dim expression of CD5. It should not be moderate expression, it should be negative to dim expression. Okay. This is the criteria to call ETPLL. So near ETPL is the one which fulfills all these criteria 1, 2, 3, 4 except for criteria 5, where we have blasts expressing moderate levels of CD5. So if CD5 expression is there, it is ETPL, near ETPL. CD5 expression not there, it is TL. Sorry, it is ETPL. Clear? And we can have based on the percentages also, or we can have based on the log intensity of antigen expression also, right? That we will discuss now. So coming to our case again, CD45 is dim, and we have nice CD7 expression for lineage commitment. We have CD7 expression, cytoplasm CD3 expression indicates that it's a T lineage and its MPO is negative, so no myeloid lineage. Then we have to look for your, you have to classify TALL according to these categories. Is it conventional TALL or ETPL or near TPL? So for that, we should have negativity for CD8 and negativity for 1A. So if a T lineage oriented cell is negative for CD8 and CD1A, then we have to look for expression of 34 or myeloid related antigens. So in this case, 34 is positive and 117 is positive, so myeloid related antigen. So now we have two differential diagnoses. What are those? ETPLL and near TPLL. So that decision is taken based on your CD5 expression. In this case, CD5 is positive or negative?
CD5 negative.
Negative. Okay, this is my positive CD5 positive cells, which are my T cells. Here, these are dead negative cells, right? Because any population just lying here, the simple funda is any population for any both of the antigen y-axis x-axis is lying here, it is negative. You don't even know this, need to know the cell. Okay, any cell, it can still be a neutrophil or a lymphocyte, B lymphocyte, whatever. If it's lying here, it is negative. So the intensity of this population is as the intensity of this negative population. So it is negative. Don't think that I don't know this cell. This is a negative population here. This population intensity is matching this. It is negative. As simple as that. Clear? So now we have to dissect how CD5 expression is there. So the criteria applies here. So the blast dim negative dim blast less than 78% of blast should be positive, right? So here only 7% of blasts are positive. So it means that CD5 is negative. So this is a diagnosis of your ETPLL. So 5 is negative. So we had T lineage oriented cell which had 34 expression, 117 expression, and CD5 negativity. We call it as ETPLL. Now coming to last few scenarios, CD45 is dim and CD7
Positive.
Ruchika? Positive.
Positive.
Positive. Dr. Swati, cytoplasm CD3 expression?
Positive.
Positive. And CD8 expression?
Positive.
Negative. No, CD8 is negative.
Negative.
And CD1A?
Negative.
Negative. And coming to your myeloid antigens and 34 is positive. It is heterogeneous expression is there. Yeah, 117 is negative. As in previous case, 117 is positive. In this case, 34 is positive. And 33 heterogeneous expression, a dim expression. Yes. So we have 34 is there and myeloid antigen is also there. And now we have to entertain a diagnosis between ETPLL and near ETPLL. Right. So compared to previous case where expression of CD5 was at this level, here in this case, it is going and touching the level of up to my T cells. Okay. So now let's refine the criteria and see. In the previous case, the blasts were only 5% were positive for CD5. Here, 86% blasts are positive. So indicates that CD5 expression is there, right? So this case, we are having negativity for the T lineage oriented cell, which is negative for CD1A, negative for 8, having expression of 34 and 1 myeloid antigen. Apart from that, CD5 is positive. So this becomes a near ETPLL. Clear? So difference between ETPL and near ETPL is based on the CD5 expression. Okay. Now Case 3. This is the last case. So CD5 is dim. CD7 is nicely brightly expressed. Cytoplasm CD3, Dr. Ruchika?
Positive.
Positive. So it is T lineage is oriented. So of CD8,
Positive.
positive. CD1A,
Positive.
Yes.
Positive.
So now we need not entertain the diagnosis of either ATP or ATP. The game is over here itself. Okay. So since either 8 or 1, either one of them are positive, then we should not enter the diagnosis of ATP and ATP. So this case becomes a typical TAL. Even if your myeloid antigens are CD34 is positive, irrespective of a CD5 expression, this case becomes a TAL, right? So you're clear, right? T, ATP, near ATP. So I think that's all from my side. Any doubts?
No.
Okay. I know you're all exhausted. Second session. Any doubts? Any? Oh, I didn't check my chat box.
No, sir. There are
Thank you so
no
much.
questions.
Okay.
Thank you very much, sir. It was a very informative session.
Thank you.